So our group decided to focus on a therapeutic implant for ACL repair and regeneration. Our group identified a massive need for a new system of ACL repair and regeneration. These ACL repair surgeries are among the most common sports medicine procedures, totaling about 100 to 200,000 each year. The ACL is attached to the femur and the tibia, providing a major chunk of the structural support in a knee, as it provides about 85% of the total restraining force of the anterior movement and prevents excessive tibial rotation, as well as guiding instantaneous center rotation of the knee. With all of its major functions come some major downsides because, unlike other ligaments, when injured, the ACL is inhibited in healing itself as a result of it being surrounded by synovial fluid in the knee. The current solution to ACL tears is a total reconstruction with an autograft from either the hamstring or patella tendon. The procedure is done arthroscopically, and the damaged ACL is removed first. Drill holes are made in the tibia and femur to create future anchors for the new ACL, and the grafted ligament is then pulled through the holes and secured into place. This process has many disadvantages, such as longer surgical times, increased postoperative pain, donor site morbidity, as well as a higher risk and rate of failure as the graft may not take. Even successful surgeries have given patients unsatisfactory results. With these current methods of ACL reconstruction are not completely effective for returning those injured to their normal activities and often leaves them at risk for developing osteoarthritis. And it has been found that their expectations about their recovery have far exceeded the reality of their situations post-op. Research has shown that biologically enhancing the repair can lead to a higher success rate with ACL reconstructive surgery. And new techniques such as bioscaffolds, use of platelets, platelet-rich plasmas, and the use of stem cells are all techniques under evaluation. The use of these techniques can help mimic the natural environment for regenerative ligament and could increase the success of ACL reconstructive surgery.
There are a couple of different treatments to be considered for ACL transection. Looking at the images on the screen, the first image shows an ACL ligament that is torn. The second image shows a conventional ACL reconstruction that is the market standard using a patient graft to replace the ligament. The third image, C, shows a bioenhanced ACL reconstruction. An example of this type of reconstruction is the bridge-enhanced ACL repair treatment currently undergoing its clinical trial. This method uses a sponge scaffold injected with patient blood to stimulate self-repair and is absorbed over time. Then lastly, the bioenhanced ACL repair that our design falls underneath that uses a continuous blood source to promote self-repair.
Risks of current grafting methods used for ACL reconstructive surgery can be resolved with the bioscaffold, which does not present the risk of donor site morbidity, and the fabrication process can replicate the environment in vivo to increase the success of the reconstruction. The scaffold can be used as a patch to reconnect the torn ligament and induce the healing through the material's support of cell proliferation and seeding of cells. Currently, there are more than 100,000 ACL reconstruction surgeries performed each year. About 1 to 8% of those require a second surgery, and of those, about 14% require a third surgery. The most common causes for ACL reconstruction failure are misplacement of the graft, non-anatomic placement of drill holes, failure of fixation, graft failure, and anthropofibrosis. As the scaffold can be sutured in, it limits the risk of misplaced drill holes and does not require fixation to the bone. It can be made to any length, which can eliminate the issue of graft length. Recent reports have noted a 15% rupture rate of allografts used in ACL reconstruction due to a low level of immunological reaction, which can weaken the graft and cause early failure. Since the scaffold can be made of biocompatible materials, replicate the environment in vivo, and be seeded with cells, it can reduce the possibility of adverse immunological response. While anthropofibrosis is the formation of scar tissue after injury or surgery, leading to a decreased range of motion in the knee, it can be diminished early by a full range of motion exercises both before and immediately after surgery. The use of a scaffold can provide full ACL length to allow full range of motion and reduce postoperative pain, which can allow for earlier implementation of physical therapy and anthropofibrosis preventative exercises. The image on the right is of a failed ACL graft. It caused a widened diameter than the previous ACL tibial reconstruction tunnel. In some patients, the tunnels will become larger than when they were originally reamed, especially for hamstring autografts or cadaver allografts. In 2020, the average cost of ACL surgery was $14,800 for the surgery alone, which does not account for the cost of the graft used, hospital fees, and postoperative doctor's visits. The ACL autograft costs around $510, and the allografts cost $1,300, while bioscaffolds, specifically collagen, can cost around $30 for 9 millimeters or $75 to $140 for 22 to 41 millimeters respectively, which is the average length of the ACL, indicating a reduction of graft price when using bioscaffolds.
So our solution is a dual material scaffold made of collagen and silk, and it will be sutured to the torn ACL and seated with stem cells and platelets. The following properties that it plans to have are in the mechanical, biocompatible, and biofunctional categories. So biomechanically, it needs to be strong in tensile and in bending, as well as have similar elastic properties to the native ACL. In terms of biocompatibility, it must be bioactive and non-tumorigenic. For biofunctionality, it has to survive in a synovial fluid environment and induce a fibrin clot. And for the blood supply, we will implant the scaffold subcutaneously prior to moving it to the final location so that it could become vascularized.
For our scaffold, we have two primary materials that will make up the base matrix. The first material in the bioscaffold is collagen that is naturally produced in the body to repair injured ligaments, making it a great biocompatible option. The second material is silk that has woven fibers which meet the mechanical requirements of a native ACL, and they support cell proliferation, which supports our regenerative design goal. These two materials make up a silk collagen sponge-like matrix, which forms the fundamental structure of our bioscaffold solution.
Many types of immune cells have been seen to function in earlier vascular formation, macrophages being seen as one of the most important cells in this process. This cell type has the ability to secrete and produce various bioactive molecules, such as vascular endothelial growth factors, basic fibroblast growth factors, platelet-derived growth factors, as well as tumor necrosis. These all play vital roles in controlling the neovascularization and vascular remodeling of the ligament, as well as the promotion of tissue endogenous stem cells proliferation. The lack of these cells, as well as the gradual depletion seen in some ACL repair methods, is completely destructive to these vascular formations and the overall wound healing of the ACL. This is why our design looks to mimic this early inflammatory response and repair process, especially macrophage recruitment and activation through subcutaneous implementation of the device prior to stitching it into the ACL. Anterior midline skin incisions and lateral parapatellar entherotomy will be used to expose the subcutaneous cavity to aid the process. The scaffold will then be implanted and left to mature for allowing vascularization and macrophage recruitment to occur, which was shown to take about 2 weeks based on previous studies. The scaffold would then be removed in a second surgery and moved to proper placement in the ACL for patching.
In ACL repair, the bioscaffold is sutured through a tibial tunnel to be anchored in and then sutured into the broken ACL ligaments to promote self-healing. With our device, the scaffold is being used as a patch between the two ligaments. Since it is vascularized, a biocompatible tubing will be pulled through the same tibial tunnel. The blood supply closest to the ACL is the middle genicular artery that is at the back of the knee joint, and the blood acts as a biological stimulant and promotes a continuous self-healing process after insertion.
So for our scaffold fabrication, the collagen sponge will be prepared by freeze-drying collagen in an aqueous solution, and the silk will be electrospun into nanofibrils and knitted together for added strength to create that backbone. And after sterilization, the scaffold will be seeded with stem cells and platelets.
Scaffold will be sterilized to rid the scaffold of all organic and inorganic contaminants prior to bodily insertion. Since collagen scaffolds cannot be autoclaved, it will need to be chemically sterilized. The scaffold will be sterilized by soaking in a 70% isopropyl alcohol solution or phosphate buffered saline bath. After soaking it, the scaffold will be rinsed with any water to wash away any harmful residue.
The expected mechanical properties of our ACL follow what the native ACL holds. So the average stiffness of the native ACL is about 41.9 newtons per millimeter. It has a maximum mean strength of 204.8 newtons, a stress and strain at failure, respectively, of 25 megapascals and 0.3, an elastic modulus varying between 100 and 130 megapascals, and a toughness of about 3.3 megapascals. These values vary slightly between females and males.
Since bioscaffold is vascularized, a biocompatible tubing will be pulled through the same tibial tunnel as the scaffold to provide continuous blood flow. Additionally, the scaffold can be seeded with platelets from the original blood source to induce cell proliferation and self-healing. Platelets interact with the coagulation system, causing platelet control of thrombin generation, fibrin formation and structure, and anticoagulation. This relates to the protein generation of thrombin, an enzyme that converts fibrogen to fibrin and the reaction that leads to the formation of a fibrin clot. Collagen is naturally produced by the body to repair injured ligaments and tendons, forming threads to connect them. A silk fiber matrix is also desirable for our bioscaffold because its woven fibers meet the mechanical requirements of a native ACL and support cell proliferation. Silk biomaterials are biocompatible when studied in vitro and in vivo. Silk scaffolds have been successfully used in wound healing and in tissue engineering of bone, cartilage, tendon, and ligament tissues. A cell source is required to assist the reconstruction process to promote tissue ingrowth within the sponge and assist in the mechanical loading. Two different cell types can be used to simulate repair: ligament stem and progenitor cells to produce fibroblast cells that have been shown to be effective in similar studies. The overall fabrication of the bioscaffold can be done while simulating an in vivo environment. This will ensure that the scaffold can survive in the synovial fluid environment when implanted into the body.
In order to ensure that our product design will be able to meet the previously described mechanical properties, there are a few types of functional testing that will need to be performed. This includes tensile testing and compression testing to assess cyclic elongation and load failure. Also, a 3-point bending test is required to simulate the forces applied to the scaffold within the body. We are looking to evaluate the stiffness of the scaffold and its maximum load, as well as its elastic modulus.
Our scaffold will also be tested in vitro for both degradation and cytotoxicity. So for degradation, our scaffold will be submerged in a pernase cell culture. Pernase is known to quickly degrade collagen, and therefore the test would simulate a worst case scenario, and the time and degree of degradation will be recorded under this pernase experiment. For cytotoxicity, fibroblasts are typically used. So the scaffold will be left in a fibroblast solution for about 2 weeks and checked every few days, and it will be stained so that the live and dead cells can be differentiated.
To demonstrate the effectiveness and viability of our implant, we need to conduct in vivo testing. This will help us assess the differences in a subcutaneous implant versus non-subcutaneous and how the body adapts to them, as well as how the specimen handles the implant. To do this, we'll be doing a rabbit scaffold implantation preliminary trial, and this follows the ASTM standard listed above. To test the difference in the implant success rate when planted subcutaneously for 2 weeks versus not being implanted in that way, the use of rabbit testing models in vivo will be needed. The implant will be implanted under sterile conditions in an anesthetized rabbit, and the implantation site will be marked. This will be done to assess the vascularization of the ligament and to see if there was an inflammatory response created. These factors are vital for the success of the implant, and to do this, we would use a histological assessment to examine the tissue. In addition, we'll also be looking for how the rabbits deal with post-op pain and maneuverability. In terms of a histological assessment, this is a gold standard when it comes to tissue examination. This technique is used to assess the inflammation or healing stage, as well to monitor the presence and distribution of degradation products that could dissolve into the surrounding tissues. We would use hematoxylin and eosin staining, as well as mason trichrome and safranin O staining. We would use histological storing to assess fiber structure, fiber arrangement, vascularity, inflammation, as well as cell population of each ligament. And in addition, we will follow the ASTM standards and categorize the tissue response in regard to acute inflammation, chronic inflammation, granulation tissue formation, foreign body reaction, or foreign body giant cell formation. We will also conduct TEM. We would then assess the collagen fibril diameter within the 2 different regenerated ACLs. The samples will be infiltrated and fixed with epone araldite resin, viewed under TEM image, and then measured at 2, 4, and 12-week timelines. We would then use MRI imaging at a 12-week post-op timeline, and these images would be taken by an experienced engineer, and the parameters would be set to their desired specifications as well. This would allow us to assess the bone tunnel healing and articular fluid distribution, and would tell us how the body is dealing with the implant and overall healing process. We would then perform immunohistochemistry, which will also be used to give us an idea of how the vascularization process is going in our samples. Monoclonal antibodies against alpha smooth muscle actin and CD14 will be used to detect the presence of blood vessels and inflammatory cell infiltration, such as the macrophages we were talking about earlier in the scaffolds. Now, when it comes to in vivo testing, we do have some limitations. While testing in vivo in rabbits would give us useful data, They may not fully mimic human physiology as well as mechanical conditions, and some people may not accept these animals as a proof of concept model. So in future studies, we may have to adjust that to our testing.
There are a few potential problems that come with the new design style for ACL repair and reconstruction. The most integral one is its comparison to standardized ACL reconstructive surgery. The market standard is a proven reliable method using a patient graft with an incision to harvest, but is otherwise arthroscopic and is a standardized healing and physical therapy procedure. The second flaw in our design integration is the surgeon and patient potential aversion to a secondary surgical procedure to insert this scaffold subcutaneously and then again for the ACL repair surgery. The final concern is surrounding the need for continuous blood supply. Our design utilizes the tibial tunnel formed in surgery, tapping into blood supply closest to the ACL. That is at the back of the knee joint. This is something that is being studied by others and has potential in our design process. Thank you, and please let us know if you have any questions.